Hello, everybody, and welcome to ReAligned Healthcare. I'm your host, Dr. Yauheni Solad, and today we have a great guest with us, JaredConley, the physician who is leading a digital transformation in a lot of care at home. Jared, welcome to the episode. Can you start by telling a little bit about yourself and how you actually end up leading a lot of digital transformation with care at home?
Yeah, absolutely. It's so good to be with you, and thanks for the invite. Had a lot of great conversations with you in the past and look forward to diving in. So yeah, I mean, essentially, so I'm an emergency doc at Mass Gen. I've been here for, several years now. And then I also run the help lead our healthcare transformation lab, which is really poised to see and look at all the current and emerging technology and to find out ways that we can better embed that into healthcare process so that we can really try and achieve the quintuple aim. That's a really challenging reality, as many of us know. We've seen the data from CMMI. Many of you remember the batting average that they, have recently, right? I think there was about 5 studies out of the dozens of studies that they looked at once the ACA had gotten passed to actually be effective at moving the needle towards the quintuple aim. And really, again, not that many of them actually succeeded. Only about 5 showed improved quality and lower cost. And so we've really tried to look carefully at what does the evidence show, where we really lean into the digital transformation of healthcare. And we really think that opportunity is around decoupling care from facilities, and particular moving acute care to the home. And so, as many of you know, Mass General and Brigham and Women's Hospital both went on a journey to explore that space about a decade ago. And I was a key, part of that transition. And we really, it took a village. We really all looked into kind of what are the opportunities to leverage digital and leverage this shift in care from facilities to, again, the point of need, which is generally the home for most people. And so it's been a long, wild journey. I think many of you guys have seen that, we're now a combined program across Mass General Brigham, and we think we're the biggest program in the country. I think there's evidence that that's the case, although we always like a good competition from our colleagues to really, again, push the needle. We're trying to move towards 10% of our acute hospitalized patients to be hospitalized at home. And, there's technologies at the core of that, of course, as well as people and process. So pause there and get any follow-up from you.
That's interesting. So let's try to go deeper into that, because depending on what side you're trying to take, and we're trying to look a lot of this from perspective of healthcare system, from insurance, and most of the patients. It's been a very interesting decade in healthcare. We had a global pandemic. We had a rise of telemedicine to the point where everyone predicted we'll be doing most of our care remotely. And now we seem to get back to the previous normal. So when you start looking at this a decade ago, what was the primary driver? Were you guys looking to expand capacity to ensure that's only people who need a higher level of care coming into the admissions and admitted to the hospital? Or frankly, looking more on the technology innovation and asking what if question. Now I have this incredible technology. What if I can better apply it to take care of my patients? So what was the primary driver for the program to start?
Yeah, great question. I mean, at the end of the day, we really do want to do what's best for our patients. And that can be hard to do. There's a lot of conflicting agendas at play. But what we really looked at, and we need to really credit a lot of the geriatricians in this space, who decades ago, including Bruce Leff and many others across the world, in fact, looked at how patients were doing when they were in the hospital. And they found particularly our seniors did not do well there, right? And so this really, I think, was the catalyst for us to start thinking about better ways to redesign the delivery of acute care. And it was really, again, we have to credit a bunch of geriatricians and our patients who kind of were telling us for a while, right, that they don't do well often in the brick and mortar hospital. And so that really sparked some initial evidence generation, led by Bruce Leff at Hopkins. And really, there was several of us in this space that began to think about and review the evidence, right? I mean, so many of us, really, it's exciting to try and improve healthcare, but at the end of the day, too many things have been tried and way too many have failed. And so we're really trying to look through the lens of what does the science show us and what does our gestalt tell us from being on the front lines of care. And we really found that intersection of, wow, at the end of the day, we really think we can deliver the same type of acute care experience, but in the comfort and convenience of home. And so, again, there was a lot of different currents at play, a lot of cost pressure, of course, always, but most principally, it was patients telling us that they really didn't want to be there. I often talk when I speak at conferences that, one of the most common refrains we hear in the hospital as physicians is, "Doc, when can I go home?" Right? It is a common refrain across emergency departments, inpatient wards, et cetera. And we really want to we wanted to hear that refrain in a laser-like focus and really think about how can we deliver this care that we're doing in the hospital and doing it at home. And so it was again, a bunch of different trends playing into this. But at the end of the day, it was about being laser-focused on patients, where they wanted to receive care, and could we really use the latest science and technology to deliver that kind of care in the home? I mean, at the end of the day, right, it's much like the good old days, right? Marcus Welby going into the home. This is not a new thing for us. The problem is healthcare, as we all know, came about with a lot of technology that then got centralized in the hospital. And now we have a really cool opportunity to kind of decouple something that was brought together very, sternly, which was technology, care, and facilities, and really try and break those apart through science, a bunch of physician innovators in this space. And of course, our colleagues in industry and in startups really helping us with a lot of the technologies that we need.
As a former hospitalist, I can confirm that, "Doctor, when I can go home," is indeed the first question most of the time. Yeah. Especially when you do the rounds outside of ICU and emergency department. It's interesting because, as you know, I was trained outside of the United States. So my medical school was in Eastern Europe, where you actually cannot admit everybody. And one of the interesting observations when I came and did my residency here is how much we admit here versus other countries. So a lot of the patient that would not even closely qualify for admission being admitted completely in the United States. So that was a very interesting observation, especially when you start talking about, community-acquired pneumonias and something that's less complicated. In a lot of countries in the world, this is not even close an indication if you're stable. And back in the training, a lot of us were surprised. So I think to a certain degree, we are going back to the mean of over-admission to something that's way more manageable, because of course you cannot scale a lot of resources to admit everybody all the time. On top of that, patients actually do not want it, right? If it's would be something that patients are looking for to stay and spend more time in our hospital hotels, but they're not. So it's 2024. We had this amazing push with telemedicine and, virtual hospitalist programs. And at some point, if you remember, when all the virtual hospital programs started to pop up, it almost felt like we are 1, 2, 3, 4 years away from this being the massive success. And virtual hospitals will be everywhere across the United States. But it's 2024, and we seems to go a little bit closer to status quo. We're still better than we were, but we're no as far as we wanted to be, and maybe we were too optimistic. What's happened? Do you think we still have some of the incentive structure that need to change from the way we actually administer and pay for our care at home? or there are, more fundamental alignment problems that we have to deal with.
Yeah. At the end of the day, the reality is such that we still have some really strong undercurrents that are keeping the status quo, right? And I think principally that is really kind of going to be a continual challenge as we move forward, as we think about trying to, again, deliver the patient's plea, right? Doc, when can I go home, right? And those are principally payment related and culture related, right? And so the payment structure is such that, why we do have this CMS waiver that allows us to deliver this care at parity from a payment perspective, for those that have, again, applied to CMS and gotten the waiver, which is, I think, north of 320 hospitals in the US right now. We actually are still, right, this is an extension of a waiver from COVID, right? So we are actually, there's a couple bills that have a lot of bipartisan support that there's very good evidence should be passed during the lame duck session, which is this next month before we have a transition of power. And so we're hoping that we'll get a 5-year extension from that. And I think once you see some payment uncertainty become less of an issue, right? That administrators, CEOs of hospitals, et cetera, can see that, oh, we've got a 5-year runway instead of a 2-year runway. I think you'll see a lot more activity in this space. I think if we had a permanent payment model, it would be even more robust. Because the reality is, at the end of the day, we have this really massive problem in healthcare, which is we have these fixed structure, incredible societal resources called hospitals, right? And it takes us, at least in my city of Boston, it takes about 10 years to build a new hospital, right? By the time the idea comes to fruition, you get permission from the city, you raise all the funds, you build the building, it takes about 10 years. Now, I know some parts of the country, of course, a little faster than that. But we have a demographic trend that is going to be impossible to keep up with, right? So we have capacity crunches across most urban centers across the country. That's only going to get much more tight as we get our baby boomers, really reach kind of age 75 plus, which is going to happen increasingly over the next several years. Where right now we have 11,300, I believe, people turning 65 every single day, right? And that number used to be 10,000. So you can imagine just, this number, as it continues to rise, we will not have the inpatient beds to care for them. And so that will drive, I think, some important change, both from a payment perspective. The good news that we know with the bill is that CBO has actually showed hospital at home to be budget neutral at least. Many of the studies, of course, have shown that it actually does save money, but in the eyes of CBO, as it's currently been written up, it's actually at least cost neutral, which is very important in terms of getting bills through Congress, I think, as many of us know. But at the same time, we have a really strong, so that's the payment side. We have a really strong issue also with the cultural side and our traditional practice of medicine, right? You and I both know that most of us, when we hear or see someone that's hospital sick through the data, through seeing them on exam, we actually have always been taught, and it's in our, mindset, that we have to put them in the hospital because they're too sick to go home, right? And so culturally, there's a lot to kind of rethink. Bruce Left often compares this to riding, if you remember the TED Talk video about riding a bicycle, where someone's friends made left, right, and right, left, and it took them months to learn how to ride a bicycle that way. And Bruce often quotes that, and I like that because I think it really is all about rewiring our brains to understand that, actually we can deliver this care safely to hospitalized patients in the comfort and convenience of their home. So I think the biggest problems are cultural and payment. And the good news is we have increasing data, and physicians respond generally very well to data, showing that this is a safe, effective model of care. And I think the policymakers will come along with us as we continue to build more and more evidence to show that this is an effective model of care. And frankly, again, it's one of the few that CMMI has studied and has actually reached much of the quintuple aim as best we can measure it.
Wow. So we are truly very close to potential breakthrough, because
I hope
if we
so.
have 5 additional years, we'll have even more evidence, and our care may look drastically different. So let's use this as a segue into the technology and overall experience aspect of this.
Before we do that, can we talk actually a little bit of process for those people that don't understand hospital at home and what we're talking about?
Of course, let's dive in the process, and then maybe during the process, when you talk, especially if you see some of the gaps when we currently have from the patient experience or clinician experience perspective, just name it, because I think that's maybe even more impactful to talk about than just a pure tech.
Sounds great. I'm a huge tech guy. I really want to get into tech, but I think just to understand process and what does hospital at home actually look like. And I think probably the best use case is to use the case of heart failure, right? You have patients that, again, it doesn't mean their heart has failed, right? It just means the pump itself is not pumping as well. And so you can actually have buildup of fluid in the lungs, obviously the rest of the body as well. But often these patients, it's actually the second leading cause of admission for Medicare. So it's a big part of what causes our seniors to get admitted to the hospital. And many times these patients, right, I'm an emergency doc, I see all types. I see the very mild to the very severe. But the majority of heart failure exacerbations are when they failed an increase in their medications that help them get rid of that fluid. And they're needing IV medications, stronger medications to help them get that fluid off. And so, again, the cardiologist or the PCP might have tried to increase their oral dose. That didn't work. It wasn't sufficient. So they send them to the emergency department. And we do a workup, right? It's an important workup that needs to be done to make sure the heart and lungs are okay. And there's other causes to this problem. But once we've kind of de-risked the situation, what they really just need, as you know very well, is daily IV medications, usually IV Lasix, and a diuretic, right? And daily lab checks. And again, a physician to see them daily, nurses to see them daily, and APPs where it's relevant for your care model, as part of that important team. So, this is hospital level care for a heart failure patient. The same could apply to many other infections of the lungs, like pneumonia, the kidneys, right? These are patients, again, that aren't sick enough to need the ICU, don't need emergent surgery, but also aren't low enough risk that they could just go home on oral medications, right? These are in that middle group that they need IV medications, daily or near daily labs, depending on the patient population, and then a daily clinician evaluation, often, more than once per day. So this is the segment we're talking about. And these patients get, again, largely the same care that they get in the hospital, right? So as been worked out by CMS, they're getting 2 visits per day by a nurse or a paramedic. And oftentimes that's where labs are drawn. It's where medications are given. They're getting a daily physician visit. And the first visit needs to be in person, but after that, it is actually up to the physician to determine whether that visit could be in person or virtually, like you and I are conversing now. And that can change actually, during their episode of care. And so essentially what we're trying to do is mirror the exact same care that they get in the hospital, but deliver it in the home setting, right? And for those that have higher risk, we actually, we'll talk a little bit more, but we do use technology, and that technology is often, a wearable that will help us get the sense of their vitals, whether continuous or intermittent. And, we'll obviously have all sorts of technology that allows us to deliver medications that they need and to communicate with us, right? Because, obviously a home is often some distance from the hospital, which is different from the nurse being around the corner of your unit. So hopefully that gives people just a little bit of a sense of what hospital at home looks like. We, again, are managing at our Mass General Brigham program often dozens and dozens of patients every day. It kind of varies, but we're trying to, again, shoot for 70 to 80 patients per day in our program, and we're continuing to grow. And, ultimately, we, again, try and want to make this at least 10% of our visits for our hospitalized patients at Massachusetts General Hospital and Brigham and Women's and our community site.
That's great. So in this process, where you currently see gaps from the clinician perspective or the patient, or everything that's we currently set up works like a charm and we just need to scale the system?
Where are the gaps? The largest gaps are people forget that, how much effort it takes to build a hospital, right? Anyone that's done that, right, it's months and months, years and years of work, right? And too many committee meetings. Unfortunately, right, again, there's a lot that we're doing when we start a hospital home unit that people don't realize. There's a lot of upfront costs. So there's a lot of upfront planning that needs to happen. Because literally, it's as if you're building a hospital with everything except for the actual physical nature of it itself. And even that sometimes, needs to be taken care of too, right? We need transportation and this, that, and the other. Sometimes that's own personal cars, but sometimes, for instance, for our paramedics, our program is actually, again, has some logistical management in cars and such that we build out and use. But at the end of the day, the gaps are really around a lack of knowledge around how much it's actually going to take to build this. It requires a lot of administrative support from C-suite on down, and really then understanding that you need the executive sponsorship, you need the logistical kind of sweet sauce to be able to get all of these things to the patient in their home when, on time, right? We're so used to having Amazon and getting whatever we want within 48 hours, almost with surety, not quite. But we really need that and more when it comes to delivering hospital level care at home. And so having that whole logistical arm to be able to deliver this is probably often one of the biggest gaps that we see. And so people have to do a mix of kind of, bringing things to vertically integrate and have control over the logistical supply chain, or also partnering with a bunch of different third-party vendors to enable this to happen. And so we've been at this 10 years. We've had all sorts of different iterations where sometimes it's vertically integrated, sometimes it's not, depending on the service. So there's all sorts of potential gaps because, again, this is like truly hospital level care at home. But at the end of the day, there's a lot of great resources to help any kind of institution that wants to do this that hasn't had that experience. A lot of work through the Hospital Home Users Group. You can check out our website where we, provide a lot of the resources that help address some of these gaps for those that are thinking about starting a program.
So I hear a lot of administrative challenges, including the budgeting, planning, and then setting up the logistic part. From the clinical perspective, I'm a hospitalist, emergency medicine physician. Do the regular clinician, let's imagine we decided to launch the program somewhere in a new hospital that's never had an experience. Do you need any additional retraining, or regular hospitalists who will just learn more about the programs can start picking it up and managing patients in a new way?
Yeah, love that question. At the end of the day, again, we're rewiring our brains and how we think about managing acutely ill patients. And so it really actually does require a lot of retraining, and that really is at every skill level. So, we've played around with this a lot over the last decade, right? Who's the right type of physician to manage these patients? And generally what we found, of course, is a hospitalist like yourself is well trained for this. But at the same time, they, again, need to be trained in how to do an effective virtual visit, right? And be comfortable getting enough of the exam and history virtually that they don't always have to need to go into the home, but also to know when they do need to go into the home, right? So there's some training around that hybrid delivery of care from a physician level. Also understanding, again, training around what can we actually take in this type of care model, right? And we've done a ton of work understanding around, what conditions are safe, what risk profiles within those conditions are safe. We have a lot of inclusion and a lot of exclusion criteria. All that training needs to happen for physicians. And so generally these physicians need to be I would say they all need to be acute care trained. We found the same thing with our APPs, and same thing with our nurses, right? But the challenge there is it's really about sharing all of the expertise between those that have spent decades in the home environment and mixing that with our experience in the acute care environment. So that's not always easy, because we obviously have a lot of nurses that have spent decades doing incredible home-based care, home-based primary care, VNA services, etc. But at the end of the day, they might not know how to manage an acutely ill sick patient, or at least haven't had experience doing that in a while. And so to your point, it really is understanding all of the training needs that exist and filling those gaps as appropriate, but still sharing best practices between our home-based colleagues and our acute care colleagues.
I have to say, a lot of this new build skill, and hopefully medical school incorporating it more and more in this curriculum, requires some time and rewiring, as you mentioned, because without naming the programs, I remember working with one of the early telemed programs where we're trying to decrease nursing home readmissions after CHF specifically. And we clearly see the difference between who is on call from the hospitalist perspective, because people who did more virtual care and were comfortable asking the nurse to do assessment or assessing it virtually somehow send way less patients to emergency department. Sure. Because to a certain degree there is this reliance on, I cannot listen myself, right? That was pre digital stethoscope wide availability for everything. I cannot touch the patient. I cannot immediately assess physically. That's an indication for emergency visit, and it's not, because there are so many additional data points you can collect. And it's interesting because to a certain degree, technology helped to facilitate, right? Like our remote stethoscopes are more available, and it's not just one expensive unit. You can start adding it in the multiple service lines, and you get more and more sensing. You mentioned, continuous patches that's likely monitor your heart rate, your respiratory rate, and everything under the sun are there. What else can we do to ensure adoption? So I heard that we have some great blueprints that hospital administration can use and the clinical leaderships can start deploying. We can better teach our upcoming medical staff as well as occurring hospitalist emergency medicine physicians to actually be comfortable of providing care the same way. We hopefully will get incentive continued for the next 5 years. What else can we do to actually ensure that the care progressively move into home?
Yeah. At the end of the day, what I like to tell people, speaking at conferences and other things, is this is really about where would you personally like to be hospitalized, right? And I ask the audience that, and everyone always, thinks for a minute. And again, about 80 to 90% of us, maybe almost all of us actually, are often like, well, gosh, I've seen what's inside hospitals. Again, phenomenal care, but too many aspects, are not under control of the patient. The sleep is poor, delirium is high in our seniors, etc. And, how can we make this better? And so I think it's really about just breaking down our delivery of care and understanding what are we trying to do in medicine, right? And what we're trying to do is heal people and heal them in an affordable way, heal them in the quickest way, and heal them in the best way. And so when I think about, again, when I get asked the question, like, how do we promote this more? What we really need to be all doing is looking at it and living the golden rule, right? Doing unto others as we would have done unto ourselves. And since we know the evidence is such that I actually often argue that when it comes to acute care, hospital at home actually has the best evidence for being the optimal care model. Now, that's a bold statement, but what I will say is what we don't know is the bounds of that care. So, we can say that about certain types of patients, certain conditions with certain risk profiles and certain home environments and social situations. But we can't necessarily say that hospital at home, of course, is the acute care model of choice for everyone. It's not, right? There's plenty of people that are too high risk. There's plenty of people for which, some social conditions will make it such that they can't, at least currently, although there's some great work going on there. But if we review the evidence, we can say, gosh, look at the latest evidence from Medicare data, right? It was just published in the last couple months. I believe I helped review that article. Can't remember exactly, but there's a few great articles that came out recently. And one of the data points that came out was SNF rates post-discharge from hospital to home were somewhere around 1% to 2% versus a comparator group was about 20%, right? And so if you just look at it, like think about you, if you were held up in bed for 5 days, how would you feel at the end of that? Would you need rehab? Now imagine for a minute if you were a senior at age 80, right? We can see why people need SNF because they're being kept in bed for too long. And so I think if we review the evidence, we understand that, the clinical outcomes are the same, but a lot of the softer outcomes, right, like need for rehab afterwards, sleep, time to healing, readmissions, etc., are actually very much in the favor of hospital at home. So what we really need to really kind of make this a reality for more and more patients is to have patients understand this phenomenon. So the other thing I often say at conference settings is, I forget where you're based now, but I think you're in California somewhere. Whatever city you choose in America, right? If you're in the Sacramento area or wherever you might be now, or we could choose Boston or any city in America, really probably less than 5% of patients know that they can be hospitalized at home.
I think 5% is very generous.
Exactly. So maybe we'd get there in Boston and a few other cities that have a pretty good inroads. But let's flip that for a minute and think if 95% of patients knew that they could be hospitalized at home. Wow. My job as an emergency doc, your job as a hospitalist, like to convince patients that they need to be admitted to the hospital to get care. It's already sometimes difficult for us, right? To convince patients that they're actually sick enough because maybe they feel fine, but we have evidence in their blood work or their imaging studies that they're not so fine. But imagine if they then knew that they could actually be hospitalized at home. Our job to actually hospitalize them when needed would be much more difficult, at least in the brick and mortar facility, right? And so really, I think the crux of the matter here is all of us knowing the evidence, following the evidence, and spreading that to our patients. Because once patients understand this, I think the sea tide happens, right? Once patients know that they can be hospitalized at home safely, the outcomes are great, they will demand this kind of care. And I think that's when you'll start to see the sea change that many of us have been waiting for a few years.
And frankly, when you think from the patient experience perspective, the whole need to go to emergency department to then be hospitalized, either home or hospital, is not a pleasant experience. So whatever you can do to actually avoid going anywhere, period. So your triage actually happened before you left your home and you're staying there. So it's not that you're going to emergency department, spending your evening, afternoon, or night there, and then be told, we can admit you to the home. But you're not even coming there. You're not waiting on your stretcher outside of an emergency department. You're not waiting for the physician while you're in the room. A lot of your decision happening at home. That's, I think will be even bigger game changer, because from a patient perspective, I'm sick. I don't want to spend time outside of my four walls and be more stressed. And I only want to come to emergency department when I truly have a high probability of being admitted. So I need higher level of evaluation that I cannot do. And that's not the case right now. Like you see it possibly every day working emergency department. We have a lot of patients who are possibly should not even be in emergency department and can safely be treated, not only outpatient, but primary care physicians without any hospital visits.
Yeah, although I think you bring up some great points. What's interesting is, at least what we found in Massachusetts, and my sense is that we're finding this across the country, is the challenge is actually largely, gone are the days when people came to the emergency department inappropriately. At least at Mass General, many, some of our community sites where I occasionally moonlight, those patients exist, but they're not actually that many anymore, right? We have a bunch of urgent cares across the country that are taking some of these patients. The biggest issue, and actually we have science to back this up, what we find is patients are either there because they really need it, or they're there because they tried to get into primary care and there was not primary care capacity. So either they never heard from their doc, or their doc told them to go to the emergency department because they couldn't see them. And so, on many levels, there's a failure of the system. What this actually could be is a good transition to talk about technology and how we can see the future as we look to really kind of, again, build on people, process, technology as we think about redesigning healthcare. And what we found at the end of the day is that we think that there's a real opportunity to leverage technology to do evaluations at the point of need and to deliver care at the point of need. Now, this is going to take years to fully mature, but myself, I co-chair our Hospital Home Tech Council at the national level with David Levine and many other great colleagues in that space. And us and many others, in this village are trying to build out a research and development agenda to really help us be able to do somewhat of what you talked about, right? Where we actually, when patients have an acute need, let's say they feel short of breath, right? That we could actually mobilize a team, again, for the right patient populations where we think the pre-test probability is high enough to go in, again, the team member, depending on who it is and the need, right? Get a chest x-ray if needed, right? Get some blood work if needed, and potentially, again, eventually risk stratify them, much like we do in the emergency department, and say, actually, you can stay home. You might need an oral antibiotic for your pneumonia, but you're not hypoxic. Your breathing rate is fine, and your risk factors are such that we don't think you need the hospital. Or, actually, we found that you have a pneumonia that, given your risk factors, and you're also slightly hypoxic, you need to be admitted and giving IV antibiotics, put on some oxygen, and monitored, right? But actually, we could direct admit you from the home. And so what we're seeing is this beautiful convergence of science and technology coming together with physician innovators, across the country and even the world to say, gosh, we have built on incredible work done by our predecessors, but there is a real opportunity now to flip the script and say, we can actually deliver this care back in homes, just like we used to do a century plus ago.
So from sensing perspective, because you mentioned, do you have all the sensing you currently need to effectively operate, or sometime you're wondering, oh boy, if I only had this additional measure that's maybe real time or close to real time?
Yeah, we're on a journey there. We've done a lot of work, and including published in some of this space around sensing. There's a variety of different types of sensing, right? Wearables, ambient technologies. There's some really interesting data coming out in the kind of, vector space, in the radar space to really get it. What's cool is, like with radar, again, a patient does have to be stable, but we can actually pick up accurately their respiratory rate and their heart rate. Some great companies in that space doing work there. We piloted some of that work. So there's a variety of different technologies that will allow us to sense a patient's physiology. And again, many patients don't need that continuously, right? Patient with cellulitis that's failed oral antibiotics, that needs IV antibiotics, but is otherwise vitals are stable, etc. It's not in a scary location, right? These patients need vitals a couple times a day, right? And that's probably about it. Maybe 3 times, right? I mean, there's a lot of kind of debate about how often vitals need to be taken for certain patient populations. But whereas, like to your point, there's other patients that, they might be at risk of going into AFib with rapid ventricular rate, right? Maybe they have a history of AFib, we're diuresing them. And these are patients that we actually will put a continuous patch on and always be monitoring their heart rate and their rhythm and be able to see that from wherever we want to, whether that's the hospital where staff is based, their homes, they're in transit, right? They could pull over if they get an alert and take a look at the rhythm and the heart rate and reach out and see if an acute need needs to be addressed with in-person visitation. But sky's the limit in terms of sensing. A lot of it still needs to be further refined, because false alerts and fatigue in that regard is a problem we've had with medicine since we started sensing, right? And still is a problem in the ICUs and the emergency departments and many other parts of the hospital. So it's not that we're there yet, but we're getting to a point where it's practical, it's in use across the country and even across the world.
That's good to hear. From if we go a step up, right, from a clinician, because I think a lot of a promise of a telemedicine and a virtual care was ability to more effectively scale our scarce resource. So as a hospitalist or as emergency department physician, you potentially can share your expertise not only with people in front of you, but in a wider geographic area. And it seemed that we transitioned into this interesting new era where you technically can, in asynchronous care, making strides to the point where people are talking about this, but specialty, but it's still not as I would say well developed and developed when you can truly increase your coverage, right, and properly start augmenting your clinical decision with validated clinical agents. In your opinion, what's kind of the part of the tasks that we talk about may be well suited for additional support of those new AI agent or anything that's allow us to scale hospitalist or virtualist or emergency department physician, anyone who wants to do care at home better? Because ultimately, if you have to do the same ratio of patients to clinician, would be very, very hard to scale these programs because, as we know, people are getting sicker and we're not getting more and more medical school graduates.
Yeah, I think at the end of the day, there's a real opportunity to leverage technology in a way that we can manage more patients. We obviously, while we're not getting a lot of medical school graduates, we are getting a lot more APPs, and we've used that at our program to really expand our ability to care for patients and have a really nice team dynamic between nurses, APPs, and physicians, with obviously the physician leading the team, but in a lot of the day-to-day, that being led by the APP. And then we've also leveraged paramedics in a way where we obviously, as we all know, there's a nursing shortage. And so we've actually kind of trained up our paramedics, our community paramedics, MIH, as some of you might know, to actually being able to deliver, again, appropriate care for the patients, like giving IV medications, starting an IV, getting blood, etc. So many things that are then overseen by a nurse, right, with a clear nursing plan of care, but really, again, extending the team's capability to deliver this type of care. And so even when it comes to some of these shortages, I think between technology, decreasing the need to perhaps do things like check vitals, or even for some people, if they live alone and they're at risk of falling, right? Some of them might just need an in-person aid, right? But others might be at a different risk profile, and they actually might just need a fall detection device, right? We all just want to match, again, the patient need with the people and the technology, right? Such that we can deliver the right care at the right time in the right place. And increasingly, we think the right place is the home. And I guess one other thing that I should mention, if we were to think about what is the opportunity to hospitalize patients in their homes, well, that opportunity is probably not nearly as large for patients that are direct from the ED, because there's a risk level at that point where we don't really always know what direction an acute illness is going, right? And same thing if we had direct admitted from the home or from the primary care clinic. We've done all of those, but the problem with that is acute illness, as you know, as a hospitalist, and I know as an emergency doc, is we're at the kind of upswing of the risk. And we don't know when it's going to plateau, when the treatment's going to start working. And so for a lot of patients, actually, the opportunity to put them in their home again comes a little bit later. And we often refer to this not as admission avoidance hospital at home, but transfer hospital at home. So maybe they're on day 2 or day 1 of their hospitalization in the brick and mortar, but now we have the opportunity to actually hospitalize them at home. Their risk has been decreased. Their show response to the treatment. We can now say, actually, it's now safe for you to go home. And so there's a huge opportunity in that space. And I often argue that probably, again, maybe even half of hospitalized patients, maybe even more, could in the next several years to maybe even couple decades reach a point where we are actually hospitalizing many, many, many patients. Maybe not on day 1 always. And we're seeing this certainly in the post-surgical space, where they're getting their surgery, and for the right low-risk surgeries, they're either direct admitted from the PACU to the home or from the floor after a stable day of evaluation, and then going to the home for their care.
Interesting. While you've been talking, I also start thinking about some of the feedback from primary care practices that I heard over the years. And, not all of us, but some of us who started some time ago still remember in practice with a physician who were still coming to the hospitals and admitting people. So hospitalists was not covering 100% of all the hospitalized patients. And then we consistently added more and more clinical workforce. So now you need to admit to the hospitalist. A lot of people are not coming to the hospital. So 2 questions, actually. One, do you think if we introduce yet another specialty into this continuum of a care management, where frankly you have both rapport and a good knowledge of the patient, we increase fragmentation? And 2, is it possible that care at home, especially if it's available to primary care groups and physicians themselves, may actually return our primary care physician a little bit to the bedside instead of relying on new, constantly changing hospitalists?
Yeah, I think a great question. I think ultimately it's hard to know where that's going to go. I think ultimately, at the end of the day, I would just say some of the emerging tech that's coming out right now is totally redefining how we're going to deliver care in the future, right? I mean, gone are the days when I have to look at the screen and type in notes while I'm, intermittently trying to look at the patient, right? I just walk in, I put on my ambient documentation device. I obviously ask for permission first, had everyone but one say yes, and, go about my work. And so I'm able to get closer and closer to the bedside, with this amazing technology that's just come out right in the last year or so. And so I think there's all sorts of ways that tech and new, kind of training and process and delivery models will impact our ability to be more and more present at the bedside, whether that's primary care, emergency medicine, our surgeons, our hospitalists, whoever it might be. I think there's a real opportunity to, again, use technology to allow us to spend that precious time with the patient, right? To be able to listen to them, to hear their story, to empathize with them, and to ultimately leverage the technology to do a lot of the other stuff that we've had to do for decades that has frankly taken a lot of the joy out of medicine.
But a lot of the reason why primary care stopped coming to the hospital is not only their comfort level, right? But frankly, clear financial alignment or misalignment around that. And when we start talking about hospital at home, you have a waiver from the hospital. So if you're not a hospital, if you're a primary care group or individual physician, there is no way for you to start the program right now or kind of go into this level of acuity. And we're dreaming right now, right? So I think it's less about what's truly happened, because I think predicting what's truly happened is likely thing that's happening right now, likely at a bigger scale. But the real question is now, especially when we get more evidence and we know that things are good, maybe it's also the time to ask the question, should we have some degree of a hybrid programs that should allow primary care physicians to expand their practices? Because absence of this continuity and just being on the ambulatory part, it's something that a lot of physicians miss, and maybe a very interesting way to actually expand their practices and their desire to actually practice more of acute medicine.
Yeah, I mean, I like that. I like that thought. I think at the end of the day, the more someone knows us, the often the better they can care for us, right? That applies on so many different levels. And so, the reality is, it actually could be that primary care is best poised, again, if they're also acute care trained, to deliver that type of care. And that varies for every primary care physician, depending on how recent or long it's been since they took care of hospitalized patients. But I think absolutely there's an opportunity to do this from the role of primary care. It's just more around kind of, incentive alignment, how they want to, frame their practice. But right, I mean, as we've talked about, right, you could link the primary care doc if they desired, right, in this model such that, again, they wouldn't have to always be going to the homes, right? They could beam in and do a virtual visit, just like you and I are doing right now, and have a pretty meaningful interaction, right? There's pretty much all the history you can often get through video, right? What lacks is sometimes some of the physical exam. Now, I can tell right now, for instance, with you, right? I can tell that your respiratory rate is normal, right? I can tell that several things that are important just on what we call kind of a doorway exam, right? To know that you're not at least struggling to breathe. There's other things that we need to rely on, right? To understand physiology. And I often talk about, right? That's point of care diagnostics. It's, some of the remote patient monitoring. So you can kind of bring that all together, but could a primary care physician manage this? Absolutely, right? If they're acute care trained and they can work their schedule in, they just also have to have some time built in that if an emergent need came up, they could go visit the patient at home, right? Or have someone else do that for them, depending on the team model.
That's a great point. The last thing we want to do, add yet another in between the patient stuff.
Yeah, right.
For primary care. Great. So you've certainly seen a lot of the changes in the progress. Over the year, if you had a magic wand, right, from the policy perspective, from the incentive perspective, from technology perspective or clinical guidelines perspective, and that's a tough one because you have to pick one. What will be the single things that you would like to redesign and realign?
For hospital home care?
Yes.
I think the one thing that I would like, if I had a magic wand, would be to be able to just infuse knowledge into patients, that they can be hospitalized in the comfort and convenience of their home for a variety of conditions and a variety of needs. And I think if we can infuse this knowledge into patients, the rest falls into place, right? We see this in so many aspects, right? When the consumer knows and makes an informed decision, right? Things follow, right? So I think really what we need to be doing is infusing knowledge into the minds of patients that it is safe and effective to hospitalize them at home, again, for the right conditions and the right risk profile. Once that is known, the rest will fall into place. And I think the challenge is pulling that off, right? But you said I had a magic wand.
Of course. I also want to expand on the opportunity because, the education, and we've been talking about, patient driven decision support tools and patient education tools for decades and decades now. And it's consistently been shown that you make smarter decisions when you work together with a patient. But somehow we're still in 2024 and it's still not solved. And now we have, for the first time, technology and machines that can personalize the content, that can generate the content, that can speak your language and, frankly, increase the complexity or decrease complexity of whatever we're trying to communicate based on your particular needs. So where do you think would be the optimal site to actually start addressing it? Like, do we need ambulatory programs, go to 55 plus communities to start better educational programs? Do we need, social media campaigns? Do we need our primary care network do a better job? Do we need some additional tools for the people who are in the hospital or in the urgent care? Like, where would you start?
To educate patients?
Yes.
We've been struggling with that for some time. We've had some good impact when it comes to the lay press. There was a great ad by Mount Sinai that some of you might have seen that basically had a picture of the hospital, and it said something to the effect of, if our beds are filled, we have failed. Right? Speaking to, again, the ability to holistically care for patients as well as hospitalize them at home when, unfortunately, all that we've tried to do hasn't prevented the acute care need. So we've seen some effective work done in the lay press, which has certainly exposed patients more and more to this opportunity. But I think we haven't captured it enough. And what we're working on right now in our system is to develop an animation video to better teach patients. And I bring this up because one of the most powerful patient education videos I've ever seen was the video 23 and a half hours on exercise. I don't know if you ever saw it. I forget the name of the Canadian doc that put it together, but it's just a phenomenal video that highlights how 30 minutes of exercise a day could benefit your life. And it's just really thoughtfully done, extremely well executed in animation video, and really had a lot of impact when it came out. It's probably been, 10 plus years since it came out. Now, you could argue, well, what has that done to education in the United States, right? But I think, sometimes you still need to be able to leverage that amazing video across a variety of different channels for it to have impact. But I think there's a variety of different ways that we can have impact on patients and educate them. But one of the principal ways, I think, is to do it creatively. And these type of animation videos that are then, put out through various channels, whether that be social media, whether that be, things like, your hospital's YouTube channel or whatever it might be, I think there's a lot of opportunity there.
Interesting. I like it. Think creatively about the information we're trying to share and put it in non-traditional channels. So, because I think if we leverage our traditional channel, it's too late. because the last thing I want to do is to actually get educated when I'm about to be admitted, especially about the generic topics.
Yeah.
Jared, thank you for your time. It's been a fascinating discussion. Any parting words, anyone you're looking for from the clinical perspective, any innovators that you're trying to attract to your lab or committees you're working on, or any particular startup that's maybe currently developing new technology for care at home and looking for guidance, testing, or anything related?
Yeah, I appreciate that. It's been a pleasure to kind of dive into this with you. I think, at the end of the day, I was in the Silicon Valley area, fresh after ACA, and there's a lot of interest. And there's subsequently been a ton of interest, right? To leverage digital, to leverage the opportunities to rethink healthcare and to have massive impact. And I think the biggest challenge I've found is to frankly, essentially just be pretty disillusioned about how many smart people are working on incredible ideas, but ultimately they don't stick. Right? Healthcare is a very challenging environment. And to be able to, convince payers, convince patients, convince physicians that this is the right approach and that you should buy this particular product or service, as you know too well, right, is very challenging, right? Used to, and I think still have several roles where you're actually evaluating such products and services. So at the end of the day, what I tell those that are looking to really have impact in healthcare is look to the areas where the evidence shows there is real chance for impact. Now, there isn't always science to back that up. And there's plenty of things that need to be done just on, a hunch. And, there's a lot of great, evidence of innovation that's came out just because of a hunch or a variety of different ideas coming together from different fields often. I love the book Where Good Ideas Come From. Just a quick read that kind of highlights some of that just from a layperson perspective. But at the end of the day, what we do know is that there is a ripe opportunity to deliver home-based care. Patients want it. The evidence suggests that it actually can achieve the quintuple aim. There is so little that actually can do that. But when it comes to acute care at home or advanced care at home, it's one of the few things that's shown that it can actually achieve the quintuple aim. And so if you really want to have impact and make a splash in healthcare, come join us in the acute care at home space. Leverage your wisdom, leverage your contacts and networks and cash to really dive in to building the technology that we need in this space, to building the process that we need in this space, and certainly the people, so that we have the ability to deliver patient-centered care like never before. America needs it. Our health systems need it, but principally the patients need it. And all of us will massively benefit if we do.
Thank you, Jared. I'm certainly inspired by that, and hopefully when we'll follow up in a few years on another episode, we'll have even more things to report about how the incentives are changed and how every hospital now has a care at home program that's been growing like a weed everywhere. So thank you for your time. It was a pleasure having you for the episode.
Thank you. Always a pleasure to connect.